All right, welcome young doctors to this explainer on the extremely high-stakes process of mechanical ventilation weaning. Look, if you're just starting your ICU rotation, you probably already know that actually managing the ventilator amidst the endless alarms and your attending breathing down your neck is really only half the battle. The true challenge? It's getting the patient off of it safely. So today, we're going to take the latest 2024 clinical practice guidelines from the American Association for Respiratory Care, mix in some key insights from the European Medical Journal, and turn all of that into a totally clear, actionable pathway for your very next shift. Because let's be honest, this is the ultimate, incredibly nerve-wracking question every single ICU resident faces. When is the exact right moment to pull the tube? If you do it too early, your patient crashes, and you're looking at a chaotic emergent reintubation. But if you do it too late, you're exposing them to ventilator-associated pneumonia, ICU-acquired weakness, and a much longer stay in the hospital. You really need a rock-solid system, and that is exactly what we're going to build together right now.
Okay, here's our clinical roadmap for the shift. 1. The Ventilator Liberation Balancing Act. 2. Mastering Spontaneous Breathing Trials. 3. Rethinking the RSBI. 4. Optimizing the SBT setup. 5. Making the extubation decision. And 6. The post-extubation safety net. Let's dive right in.
Starting off with Section 1, the Ventilator Liberation Balancing Act. Now, before we can even think about pulling a tube, we need to make absolutely sure we're speaking the exact same language on routes.
Listen, mixing up these three terms is a classic rookie mistake on the ward. Per the 2024 AARC guidelines, weaning is simply the process of gradually dialing back to level of mechanical support. Liberation is the complete termination of that mechanical ventilation, and extubation, well, that's the actual physical removal of the endotracheal tube. So the key takeaway here is this. Passing a breathing trial means your patient is liberated, but it absolutely does not mean they're automatically ready to be extubated. Like if they're completely loaded with secretions and have a weak cough, sure, they're liberated, but actually pulling that tube would be a total disaster.
And to really wrap your head around why we have to be so incredibly precise with this, just look at the stakes. Up to 25% of patients extubated in the ICU end up needing reintubation within 48 hours. Think about that, a quarter of your patients. And as we know, reintubation is heavily linked to spiked mortality rates and way longer ICU stays. The stakes are just massive, which brings us to our main tool for actually getting this right. Section 2. Mastering Spontaneous Breathing Trials. This needs to be your daily clinical bread and butter to safely test if a patient is ready to breathe completely on their own.
Your standardized morning screening checklist should always rely on these core steps. Step 1, is the underlying reason they went into respiratory failure actually reversing? Step 2, are they hemodynamically stable with decent oxygenation? If yes to both, you initiate the SBT. Interestingly, the 2024 AARC guidelines specifically highlight implementing a standardized approach to knock out these SBTs before noon every single day. Why? Well, ICU culture basically revolves around those big multidisciplinary morning rounds. If you get the SBT done by noon, the whole team, nurses, respiratory therapists, the attending, they're all right there to make a unified, coordinated decision on extubation. Finally, monitor them closely for 30 to 120 minutes. Most patients who are going to fail will actually tip their hand and show signs of failure in that very first 30 minutes.
All right, Section 3, Rethinking the RSIB. If you spend any time at all reading older ICU literature, you've definitely heard of the Rapid Shallow Breathing Index. Well, it's time to systematically dismantle some old dogma.
So the RSBI is calculated by taking the respiratory rate and dividing it by the tidal volume in liters. Back in the day, like old school 1991 teachings, it was mandated that a patient absolutely had to have an RSBI of under 105 before you'd even try an SBT. But the 2024 AARC guidelines? They've completely modernized this. The new school rule is that calculating an RSBI is not strictly required to determine if a patient is ready for an SBT. Actually, scratch that. It's more than just not required. Studies show that waiting around to calculate and obsess over a perfect RSBI can unnecessarily keep a patient stuck on the ventilator for an entire extra day.
When you really dig into the data from a massive meta-analysis of over 10,000 patients, an RSBI of less than 105 has moderate sensitivity, around 83%, but pretty terrible specificity at just 58%. Meaning a ton of patients with a perfectly acceptable RSBI are still going to fail extubation. It is simply not a magic bullet. But it does still have some value on the extreme end of the spectrum. An incredibly high RSBI, anything over 105, basically guarantees they're going to fail. So treat it like one piece of a much larger puzzle, not some strict gatekeeper for starting your morning trial.
Section 4.
optimizing the SBT setup. So you've screened the patient, they're ready to test. But how exactly should you be programming that ventilator for the trial?
Man, there has been a literal war in critical care for years over this. Do you use pressure support ventilation, which gives this tiny little boost of 5 to 8 centimeters of water just to overcome the resistance of breathing through a plastic tube? Or do you use a T-piece trial, which gives exactly 0 positive pressure and forces them to breathe totally unassisted? So which one wins? Well, the 2024 AARC guidelines reviewed all the latest randomized controlled trials and essentially declared a tie. They found that SBTs can be successfully done with or without low-level pressure support. Either option is totally fine for your general ICU population. Just go with whatever your local unit protocol prefers.
However, there is one absolute, non-negotiable safety rule where the guidelines do not budge even an inch. Quote, "We suggest that FiO2 should not be increased during an SBT." Look, if a patient starts desaturating right in the middle of a trial, human nature is going to make you want to reach over and just nudge up the oxygen dial to help them out, right? Don't do it. Jacking up the FiO2 artificially inflates their oxygen saturation and creates a total false positive. You're literally just masking an ongoing underlying hypoxemic respiratory failure. If they desaturate on their baseline settings, they failed the trial. Put them back on full support and just try again tomorrow.
Moving to Section 5, making the extubation decision. Let's say your patient absolutely sails through their 30-minute SBT on their baseline oxygen. Now comes the real moment of truth.
You have to internalize this rule. Passing an SBT proves they can breathe. It does not prove their airway is safe. Remember those definitions we talked about earlier. We've successfully proven liberation. We haven't proven extubation readiness quite yet. Before you actually pull that tube, you must assess how well they can protect their airway.
So here are the heavy hitters, the strong, evidence-based predictors of extubation failure that you absolutely need to be evaluating. First up, positive fluid balance. Fluid overloads the lungs and the heart. These patients fail all the time. Second, upper airway obstruction. Always do a cuff leak test. If they fail it, meaning they've got some laryngeal edema going on, they need systemic steroids at least 12 hours before you even think about extubating. Third is advanced age. Fourth, if pneumonia was the original reason they got intubated in the first place. And finally, like we mentioned, an RSBI over 105. If your patient has these risk factors, you need to proceed with extreme caution.
And then, we've got the somewhat weaker predictors. Their conscious level, cough strength, secretion load, delirium, and ICU-acquired weakness. But listen, just because the textbook calls them weaker predictors doesn't mean you just ignore them. If your patient is wildly delirious, barely coughing, and producing a ton of secretions, pulling that tube is going to end really poorly. You've got to take all of this clinical context and synthesize it right alongside your SBT results.
And finally, Section 6, the post-extubation safety net. You've weighed all the risks, you've deflated the cuff, and you actually pulled the tube. The next 48 hours are incredibly critical. But luckily, modern critical care has some great strategies to act as a safety net during this vulnerable window.
We can be proactive and actually prevent failure using prophylactic support. For your high-risk patients, especially anyone over 65, smokers, or folks with COPD, you should be slapping on non-invasive ventilation, or NIV, the exact second that tube comes out. Extubating directly onto NIV has been proven over and over to massively cut down on extubation failure for these groups. On the flip side, for your lower-risk patients, or honestly just the ones who cannot tolerate the super tight fit of an NIV mask, high-flow nasal oxygen therapy is your best friend. It gives them warmed, humidified oxygen and just a tiny bit of positive end expiratory pressure, which really helps improve gas exchange and stops their mucosa from drying out.
But okay, I want to leave you with arguably the most vital warning in this entire explainer. Never, under any circumstances, use non-invasive ventilation as a delayed rescue therapy once post-extubation respiratory failure has already set in. NIV is an amazing prophylactic shield right after you extubate. But if your patient starts actively feeling, if they're heaving, using accessory muscles, and crashing hours later, throwing an NIV mask on them at that point is actually dangerous. The studies are super clear. It just delays the inevitable reintubation, and that delay directly causes a spike in patient mortality. If they're failing, just bite the bullet and reintubate. And that brings us to our final thought. Passing the SBT proves they can breathe, for sure, but pulling the tube, that proves they can actually protect their airway. Are you ready for both? By standardizing your morning screening, letting go of outdated RSBI rules, keeping things super strict and safe during the SBT, and smartly using your post-extubation safety nets, you can totally crush this balancing act. Take these guidelines straight to your next shift, young doctors. Thanks so much for joining me on this explainer, and I will see you next time.